Today we will be talking about seizures for our first pediatric neurology lecture. We're going to start talking about febrile seizures, which occur in 3 to 4% of all children. The peak age is 18 to 22 months, but the range is from 6 months to about 5 or 6 years. The fever can be noted before the seizure occurs, during the seizure, or in the several hours that occur after the seizure. And the fever is typically defined as greater than 38.4 degrees Celsius. Febrile seizures are divided up into two categories. The first is a simple febrile seizure, and a febrile seizure will be categorized as this type if it is a generalized seizure, meaning that the seizure is occurring all over the body from the beginning of the seizure, if it lasts less than 15 minutes, or it does not recur within 24 hours. The risk of epilepsy following a simple febrile seizure is only about 2%, and the first febrile seizure is simple in about 75% of cases. A febrile seizure is considered complex if it is the opposite of the three things we just mentioned. That is, if it's focal, for instance, if it's only occurring on one side of the body from the beginning, if there's head or eye deviation or something like that, if the duration is greater than 15 minutes, or if you have recurrent episodes within 24 hours. The risk of epilepsy following a complex febrile seizure is a little bit higher, so it's 5 to 10%, but overall I reassure families that the risk of going on to have epilepsy following a febrile seizure is still very low, and the chances are highly in their favor that they will not go on to have epilepsy. And the first febrile seizure is complex in 25% of cases. Workup for a febrile seizure sometimes includes a lumbar puncture, and this involves your first febrile seizure, not for every febrile seizure, because some kids will have multiple. So you should consider doing a lumbar puncture for the first febrile seizure in all children less than 12 months old. You could consider it in children 12 to 18 months old, depending on how they look, and only do it in children greater than 18 months old if meningeal signs are present, such as a stiff neck or bulging fontanelle if their fontanelle is still open. Or you may think about it if they've been pre-treated with antibiotics, and thus it's going to be a difficult clinical scenario to tell what's going on. Head imaging should not be performed for simple febrile seizures in most cases. It is appropriate to consider in the case of focal abnormalities on exam, or in the case of a focal febrile seizure, if they also have developmental problems, if they have neurocutaneous lesions, or a very large or a very small head size. But the head imaging does not necessarily need to be done emergently, since it's unlikely to change how you're going to manage acutely the febrile seizure, and it's generally fine to perform it later on in the outpatient setting. And typically we will be doing an MRI instead of a CT scan. EEG is typically not indicated in the workup of febrile seizures. They have done studies looking at if an EEG is going to be helpful in predicting the recurrence of either a febrile seizure or predicting whether the child will go on to have subsequent epilepsy, and it does not reliably predict either of these scenarios. So typically the only time that I would recommend doing an EEG is in the situation where you're trying to determine if someone is in status epilepticus. As far as treatment is concerned, most febrile seizures are brief and will stop on their own. If the seizure does reach the 3 to 5 minute mark, they may need to receive a benzodiazepine, which could include diastat in the outpatient setting, which is a rectal suppository of Valium, or Ativan 0.1 milligrams per kilogram IV in the inpatient or EMS setting. They clearly need an antipyretic to treat the fever, which is of course the source of the febrile seizure, and you need to look for and treat the cause of the fever, such as an ear infection or strep throat or something that may need an antibiotic. And a lot of treatment of febrile seizures is parental reassurance and education, since they are often very upset over what's just happened, think their child is dying, and a lot of this is calming them down and helping them to be equipped to handle this in the future. The next topic in epilepsy that we're going to cover is Lennox-Gastaut syndrome, which is a severe epileptic encephalopathy defined by a classic triad of intractable seizures, a distinctive EEG pattern, which shows a very slow spike and wave, which is less than or equal to 2.5 Hertz, and impaired cognitive function. The prevalence is estimated at 1 to 2% of patients with epilepsy. It's more common in boys than girls, and they usually present between 2 to 8 years of age. The hallmark of Lennox-Gastaut is medical intractability, and they generally do not respond well to anti-epileptic medications. Many of these patients will go on to develop behavioral and psychiatric problems. The cognitive problems are usually in about 20 to 60% at the onset, but within 5 years of the onset, 75 to 95% of the patients will have cognitive deterioration. The mortality rate is about 4 to 7%, which could be due to status epilepticus or other medical problems that can come in cognitively impaired children. Seizure types that these children can develop most often include atonic or drop seizures, atypical absent seizures, and tonic or stiffening seizures. They also can have partial seizures, generalized tonic-clonic seizures, or bouts of status epilepticus. Causes of Lennox-Gastaut syndrome: in 30% of cases, they're called cryptogenic, meaning there's no clear underlying cause, but in 70% of cases are symptomatic, meaning there is some underlying cause. These could include brain injuries, such as hypoxic ischemic encephalopathy from lack of oxygen at birth, genetic conditions, such as tuberous sclerosis, developmental brain disorders, such as heterotopias, schizencephaly, pachygyria, or focal cortical dysplasias, CNS infections, such as CMV, metabolic disorders, neonatal strokes, or infantile spasms, which is a very common cause for progression to Lennox-Gastaut. Treatment, as we said, is these patients are very intractable, but clearly medications are tried, and ones that have some success include felbamate, Lamictal, Topamax, rufinamide, and Onfi. Others that can be used include Depakote, other benzodiazepines, or Zonegran. The ketogenic diet can be used in some patients. Sometimes we'll put in a vagus nerve stimulator. If they have very severe atonic or drop seizures, a corpus callosotomy could be done to keep the two sides of the brain from communicating well and help prevent the falls. And if they have focal seizures, sometimes they might be amenable to focal epilepsy surgery. Now we're going to move on to absence epilepsy, and we're going to be specifically talking about the childhood form rather than the juvenile form, which occurs in adolescence. The childhood form, the onset is usually between 4 to 10 years of age, with a peak at 5 to 7 years of age. They typically have a normal development and neurologic state. The episodes are characterized by brief and frequent staring episodes. They usually last about 4 to 20 seconds and occur more than 10 times a day, where they abruptly lose consciousness and are completely unresponsive. It affects both sexes equally, and the vast majority will outgrow these with time, often around puberty. The EEG pattern is a 3 Hertz, meaning 3 spike and wave episodes per second, and it is provoked by hyperventilation, so we get them to blow on a pinwheel either in the office or during their EEG, so we can see this pattern, and the abnormalities come out by depriving them of sleep or by having them go to sleep. So during the EEG, we will not let them get as much sleep the night before, and we also like them to sleep when they come for their EEG to hopefully bring out these abnormalities. Treatment for absence, we have 3 main medications we can use. Zerontin or ethosuximide is our usual #1 pick due to its minor side effects and pretty good tolerability. Depakote works well but has more significant side effect profile. Lamictal doesn't work quite as well as the first 2 and has a longer titration schedule due to a risk of rash, so it's usually my 3rd line medication. And our next topic will be infantile spasms. This is a seizure type with an onset usually between 4 to 12 months of age. They have usually symmetrical, brief, bilateral contractions of their trunk muscles that can be flexor, extensor, or mixed. The upper extremities can be involved in either adduction or abduction. They often occur soon after awakening or upon falling asleep and occur in clusters, and crying may frequently follow the spasm. When they are not having the seizure, we call their EEG pattern hypsarrhythmia, and when they are having the seizure, they have a big, high voltage, slow wave, and then it's followed by flattening of the EEG, which is called an electrodecremental response. So as you can see on this EEG at the beginning there, they have a very big, chaotic looking pattern, and then at the end of the EEG they also have that pattern, and right there in the middle is kind of a flattening out of the EEG when they actually have their seizure. They have moderate to severe learning problems at about 70 to 90% at follow-up, and so you want to treat as soon as possible to try to prevent these learning problems from developing. Etiology for infantile spasms is either structural or metabolic, such as from hypoxic ischemic encephalopathy, brain malformations, neonatal strokes, tuberous sclerosis, or Down syndrome. Sometimes the cause is unknown, or sometimes it's due to another genetic etiology that is not structural or metabolic. Treatment, our #1 treatment is usually steroids, which could either take the form of ACTH injections or prednisolone. Sometimes we use vigabatrin or Topamax, and more rarely ketogenic diet or medications like Onfi or Depakote in the refractory patients. Here are the references. This concludes the lecture on epilepsy.